So how do I tie all of this together? Those are my disclosures. So before we start, I think me and Nick have just been to ENETS. So it's quite important that we do mention this. So it's probably quite important that we do mention this. So the well-differentiated nets have been moved aside, and the poorly differentiated nets have been moved aside, and a group has been added to the middle of that called the supratypical nets, which are basically the well-differentiated nets. And as Nick has already alluded to, the key 67 score probably plays quite an important part in this. I'm not going to talk about this too much today because this could probably take up a whole afternoon as well. But it's just important that you guys know about that. So conceptualizing the relevance of depth of response is something that I want to start on. I didn't want to start on it. I put this graph in last night when I came to the meeting. And I didn't want to put it in because it complicates things. But I think it's quite important that we complicate things because I think we, an oncologist, surgeons, respiratory physicians, need to know how we are all biologically linked. Okay? So I'm not going to suddenly start pointing out my illegitimate children in the audience, but I think it is quite important how we understand how we are linked, and we are linked biologically by this cancer. And this graph explains it quite nicely. So here we go. So if you plot tumor cells to time under treatment, okay, for a particular patient, so patients present with a number of cells at presentation, and on average it's about 10 to the power 14 cells. And that patient then gets referred. If they get referred to me, they get given some treatment, and I know that I have a limited ability to cause cytotoxicity, but if I'm really lucky, I might cause what we call a complete response on CT scan, so that this lesion is no longer visible on a CT scan, and then that person will stay in a period of remission for a little while, and then at some point, that cancer will start to become visible again on a CT scan, and we call that the progression-free survival. So that's the time there. And that's the overall survival. So when that cancer then reaches a critical number of cells in the body, that person dies. And that's essentially what we're up against. But of course, at this stage, with neuroendocrine tumors, quite often, they don't come to me, they go to you guys. And at that point, you guys do a much better job than I can do. And so what you guys do is do a much better cytoreduction than I can do. So you take the depth of response much further down. And this is for a relapsing patient, because I don't like using that word cure. Cure is a time-honored definition. It's not an event that a surgeon has the gift to say to a patient, or I have a gift to say to a patient. So actually what you guys do is you take the depth of response way down here, but you'll notice that there are still some cancer cells remaining in that person. But because you've taken the depth of response so far down, it takes longer for that patient to reach the critical number of cells that's going to kill him or her. And so you change the overall survival and improve it. But at some point, of course, that person's going to represent on a CT scan with a progression-free point, a progression relapse, which is visible on a CT scan. And then the surgeon may well pass that patient on to me, which is correct. And the net specialist, me, I will then at some point choose to treat this patient, and what in fact I'm doing there is making fairly minimal changes in the amount of tumor cells in that patient to prolong the survival a little further. And so that really is how we are biologically linked. It really depends on how these patients are referred to us and which order these patients are referred to us. But what's really intriguing is what happens here. The follow-up post-resection, what is happening biologically here between the point where the surgeon thinks they've done a good job and the person relapses. There are things happening here that aren't visible to us, and we have no technology to detect what's going on. So the first part of my talk is going to be covering the treatment of advanced disease, and I'll go through that very quickly, hopefully. And then the second part of the talk is going to be talking about how we should follow up these resected patients in a manner which is perhaps stratified, rather than just a blanket approach to it. So, treatment of the advanced patient, you can divide into the secretors and the non-secretors, the syndromic and the non-syndromic patients, and there are many therapies. The most important thing, though, is that the principle's still there. So cytoreduction is still very important, we think. Survival is very important, and quality of life is very important. But the problem with the lung nets is there are many, many options, but there is very little evidence base to it. And there is no consensus on sequencing. We don't know which order to give these drugs. But if we divide them up into the syndromic patients and the non-syndromic patients, then we can separate the talk out. This slide tells a story as well, and it's really a story of failing. So you can see that the pancreatic nets have good evidence in the secretory patients and in the non-secretory patients. The small bowel nets have good evidence also, good evidence also. The pulmonary nets, we borrow how we treat our syndromic patients from these two cancers, and we have absolutely no evidence for how to treat an advanced neuroendocrine tumor of the lung. And that all comes down to the pathways. The pathways are underdeveloped, and because they're underdeveloped, people don't want to invest in them. They don't want to invest millions and millions of dollars or pounds into doing research where they're never going to reach accrual. And that's the problem that people like me constantly meet. So, for the secretors, which is the easiest, the low-hanging fruit to talk about, what do we do about the secretors? So, the standard of care remains the somatostatin analogs. They've been around for about 35 years, and we have good experience with these, and we know that when a person has a syndrome, we can control that syndrome in about between 2/3 and 3/4 of patients. It's important to note that although the lung nets rarely get syndrome, when they get the syndrome, quite often it's very severe, and quite often they end up in crisis. So it's quite important that we know how to treat these patients. So we get control of symptomatic symptoms in about 3/4 to 2/3. We control the biochemical response in about 50% of patients. So it's pretty good. We can control the syndrome. But of course, that means that 25 to 33% of patients aren't getting adequate control. So there have been some developments. So we've moved on from the somatostatin analogs at the point where we've got resistance to the syndrome. So if we go back to the pathway, how the syndrome is created, we know that tryptophan is usually in our bodies converted to niacin, and niacin goes off and does whatever vitamin B does in the human body. But some of the tryptophan is converted to this substance called serotonin, and serotonin is a fibrotic agent. That's what causes the damage in these syndromic patients. This enzyme here, hydroxylase, is very important, and we now have an antagonist to that called telotrestat. And that drug, telotrestat, was tested in a trial called TELASTAR, which was a randomized controlled trial looking at 2 doses of telotrestat against placebo in patients that had uncontrolled or poorly controlled syndrome. And the bottom line is the primary endpoint, which was bowel movement frequency. You can see that there was a positive result, so the telotrestat was helping control bowel movement much better. There's a reduction in the urinary 5-HIAA control, which is a surrogate of the serotonin that's being produced by the body. And it was well tolerated, as long as you kept it at a dose of 250 milligrams. And so, ultimately, NICE has approved this drug for refractory syndromic patients, and it's approved it at a dose of 250 milligrams because the 500 milligrams didn't really add much to efficacy, it just added a little bit more to toxicity. And so that's syndromic patients. What about the patients, the bulk of the patients that aren't syndromic? So how do we confer cytotoxicity in these patients? Well, like I said, there's a number of agents, but as you'll discover, there's a lot of evidence that's lacking here. So the first thing we go back to are the somatostatin analogs. So the somatostatin analogs remain a real cornerstone for neuroendocrine management. So there are two main competitors on the market, and they have the same class effect. And we know that since somatostatin analogs have come along, the outcomes of neuroendocrine patients, not only for this reason, but partly because of this, the use of somatostatin analogs, the survival curves have improved. And this kind of data led to two trials, which have been briefly alluded to in previous talks, the PROMID and the CLARINET trials, both testing octreotide and lanreotide, and primary endpoints being progression-free survival. And we know that even if a person doesn't have syndrome, if you give them these drugs, they live longer. And so these have become standard of care now in that usage for pancreatic NETs and small bowel NETs, but they are, strictly speaking, not licensed for this use in lung NETs because neither of these studies involved pulmonary NETs. And a cynic in me would say that's because our pathways aren't developed. So at the time when these trials were being created, people just thought we can't be bothered with these lung NETs. But we were searching for our own evidence in lung NETs, doing a similar study to this, and I'll allude to that in a second. So the somatostatin analogs have shown they have an antiproliferative rationale, a direct rationale and an indirect rationale, so we can use them for that purpose. And because of these developments, the somatostatin analogs, people have wanted to develop them further, and so people have looked at the role of maintenance using these somatostatin analogs, and this is the trial that I alluded to. SPINET was a purely lung NET trial which had to close early, and so it was looking at the use of lanreotide to try and improve progression-free survival in well-differentiated NETs. Why did it close early? No accrual or poor accrual. Why was it poor? Why was there poor accrual? Poorly developed pathway. So it's the same theme, it's a recurring theme. So we can't invest. So people like me, I'll be unemployed if we can't improve this pathway. So please, let's improve the pathway. I've got children to feed. And there have been studies done, dose intensification and combination, but they don't involve the lung NETs, they involve the other two NETs. Okay? And that's once again because the pathway is immature. Frustratingly, the next generation somatostatin analogs were tested in lung NETs, and I'll show you the results of this in a second. This drug called pasriotide was tested in next generation. It demonstrated efficacy. We got a positive result, and then Novartis turned around to me and said they don't want to develop the drug anymore. So there you go. What about chemotherapy? So this is once again for the non-secretors. When do we use chemotherapy? So this is quite important. Okay, so for the well-differentiated lung NETs, I guess we use the chemotherapy when other therapies fail. So when the somatostatin analogs and these things called the mTOR inhibitors fail. We use it when the histology and the Ki-67 scores are adverse. So I've already mentioned the grade 3 NETs and the atypical NETs. We're more likely to use it for those two conditions than the typical NETs. For rapidly progressing cancers, we tend to use chemotherapy first. When a patient is symptomatic, we tend to use the chemotherapies. And of course, patient choice. But the practice, once again, is borrowed largely from the pancreatic NETs, cap in hand. I'm going to cut to the chase, so I'm not going to go through all the chemotherapies that we use because there's many, but there's no evidence behind a lot of them. The one that's come to the fore in the last 5 to 10 years is this thing called temozolomide and capecitabine. It's convenient for the patients because they're both oral tablets. They're reasonably well tolerated. But you can see that nearly all the trials have been small numbers, and they've all been in pancreatic NETs, not in pulmonary NETs. So we borrowed the service from them. So our centre, we have published a retrospective case series of 34 purely lung NET patients, and we've demonstrated a good partial response and certainly a good disease control rate. And disease control rate is much more important. So getting a cancer to stop growing in these cancers is much more important than trying to shrink the cancer. Okay, and so it certainly seems to be a very active agent. But to develop any trial like this, you need the pathway. So in summary, the benefits of this treatment are radiological response. We seem to be able to shrink the cancer in about a fifth of patients, but there is no survival data, which is a shame. What about targeted therapies? So for targeted therapies, I can actually quote level 1 and level 2 evidence here. So we've done quite well. The lung nets have done quite well with the proper big studies. So the use of everolimus has mainly been described in 3 studies, Radiant 2, Radiant 4, and the LUNA trial, all of which included lung net patients. So in Radiant 2, there was an unscheduled subgroup analysis of the lung cohort, and what they found was that although the progression-free survival, which was the primary endpoint, was non-significant, there was a trend, and that led them to do a planned subgroup analysis in Radiant 4, which showed that there was a strong reason for giving everolimus in a relapsing patient. And then the LUNA trial came along, which was a purely phase 2, randomized phase 2 lung net study looking at that next generation somatostatin analog versus everolimus versus the combination. And once again, it met its primary endpoint, showed good efficacy. And because of that good evidence, we were rewarded duly. So radiological response and survival benefit meant that NICE approved this drug for lung nets in 2017. And that's what you get for good methodology, I guess. What about PRRT? So radiotherapy, targeted radiotherapy treatments. So a lot of the lung net evidence is actually retrospective. The prominent studies don't include lung nets. As a consequence of that, the NETO-1 trial, which was the dominant study, was reviewed by NICE, and they approved PRRT therapy in pancreatic nets and other nets, but not in lung nets, because lung nets weren't included in this particular study. So there is a phase 1-2 study that's now started called OPS201, which includes a cohort of lung net patients. So we have another chance to recruit to that. So moving into the future, because of the history, you can see that a lot of our new trial developments hinge around everolimus, and so we are testing chemotherapies with everolimus and newer agents with chemotherapy with the mTOR inhibitors. But you'll note that there's no immunotherapy here. So immunotherapy hasn't really had an impact in this cancer. So, and the reason for that is that the results have not been impressive, but actually there is a biological reason. These cancers have low somatic mutation rates, so they don't express antigens very well, and of course they have this thing called very low MSI, microsatellite instability expression, and PD-L1 expression, which is something that you require as a biomarker to make immunotherapy work. So immunotherapies are out. What about sequencing? So very quickly, so for patients that are asymptomatic with a very low proliferation index, you can just observe them. For patients that have a slowly progressive cancer, you can give them a somatostatin analog. For patients that have progressive cancer, give them chemotherapy, and that's the choice. And for those that are strongly expressing somatostatin receptors, you can give them PRRT, and then you can mix and match at relapse. And finally, so evidence-based for follow-up. So how do we put all of this together? So like I said, this part of this graph really intrigues and really asks lots of questions. So if you look at the way that patients relapse with lung nets, most patients are, in fact, resected, so they end up with you guys. And then about 15% of the typical carcinoids relapse and about 50% of the atypical carcinoids relapse. They relapse to that distribution, so mainly liver, but lung, lymph nodes, bone, and the higher grade ones will also relapse to the brain. What we really need are predictors of relapse, and this is where we need to increase our intelligence. And there's a massive unmet need for adjuvant therapies, which I won't have time to cover. But a bit of common sense can be applied to this. So we know that the typical carcinoids are very non-aggressive, but the SEER database teaches us that as you go down the staging, the risk of relapse increases. And so, simply put, if you have a small cancer versus a big cancer versus a cancer that has lymph node involvement, you have an increasing risk of micrometastases, and they are the main enemy. And what's the problem with micrometastases? Well, before they become macrometastases, there's no way of recognizing them. Once they become macrometastases, you can't really prevent the patient from dying from that cancer eventually. And so the trick is to get them detected early intervention, better outcome. And that's really the purpose of follow-up. And so we come back to this graph. What we need here is a stratified approach. So we know two things already. We know that histology is an adverse factor if it's an atypical carcinoid, so you follow up your atypical carcinoids. We know that lymph nodes are an adverse factor, and so lymph node positive cancers should be followed up. So there we go, multivariate analysis. We know that we should be following up those two patients at least. Can we go any further? So some of this has been alluded to. So at the Christie, we've been doing a lot of work on predictive factors, trying to work out which of these factors make a difference to outcome. And in fact, all of these factors make a difference. Why isn't this standard of care? It's not a standard of care because we can't validate it. We can't validate it because we don't have the developed pathways. So these are the ESMO guidelines. The ESMO guidelines, I'm not going to go through them because you can get these slides. The ESMO guidelines are very non-generic, very generic. What they say is just follow up your patient for 15 years. And do you really want your clinics plugged up with T1A, N0, M0 cancer patients or T2A, N0, M0 cancer patients? They'll dominate your clinics. No, you don't. So what you need is actually a much more intelligent approach. So we can only validate these things if we have the pathways, but a bit of common sense. So who you must follow up? Well, you must follow up your atypical nets and your grade 3 nets, the node-positive nets, the incomplete resection, and the large primaries. Where is the grey area? The T stage. I don't really know what to make of the T stage. Lymphovascular invasion. DIP necks. Should we follow them up intensively? My gut feeling is probably we should because they are a respiratory problem. High KC7 score patients with typical nets, and of course, any emerging biomarkers. Follow-up to learn. So these are for the academic units. You might want to follow up these patients to see what the survival curves map out like. And so in the real world, perhaps you can do this. For the typical nets, you start at the T3N0, M0 cancers, any node-positive cancers, size greater than 3 centimeters, the R1, R2 resections, and any of these factors, and you follow them up with that. I'm not going to go through it all. And the atypical and the grade 3 nets all should be followed up, but you follow them up more intensely. So as you go from the atypicals to the grade 3 nets, the follow-up just becomes more and more intense. And perhaps that's the way that we should do this. But of course, what we need here is a trial of follow-up. We need a protocol. But we can only put a protocol together. And I'm happy to put a protocol together if I was confident that the pathway would then put patients into that protocol. Because even a protocol study requires millions to run. So in summary, role of systemic chemotherapy, there is a definite role for somatostatin analogs, and the telotrestat is great for the syndromic patients. For disease control, there is good evidence for somatostatin analogs based on other cancers. PRRT is coming through. The tyrosine kinase inhibitors, we have supporting level 1, level 2 evidence for them. But where we are really lacking is efficacy of chemotherapy. And of course, we now need a new approach for grade 3 nets. And for surgery follow-up, post-surgery follow-up, of course, there has to be an appetite for a national or international study looking at stratified follow-up. I think that's the only way to do this. I was going to write a new guideline last year, yet another one, and Nick kind of eloquently explained, don't, so I didn't. But I think more and more, this requires an adjuvant study, and it requires a stratified follow-up protocol. Thank you.